This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I interviewed Dr. Nathan Hudding to discuss the safe treatment of the cervical spine. Dr. Hudding currently works as a physical therapist, professor, and researcher. In our discussion, we talked about the adverse events after manual therapy, mechanisms leading to blood flow limitations, its symptoms, and how to identify them in the subjective and objective exam, the international framework for examination of the cervical spine, and if it's safe to perform manipulations and mobilizations on the cervical spine. If you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share with other clinicians if you may benefit from this conversation. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi Nathan, welcome to PT Pro Talk. How are you today?
I'm fine, thank you. And how are yourself?
Good.
I look forward to the conversation. So nice that you have me here, your podcast.
Awesome. I appreciate you accepting my invitation. So let's jump right in. Just tell us a little bit about yourself and your background.
Yes, so I'm Nathan. I come from the Netherlands, and my background is in physical therapy. And after my physical therapy education, I studied manual therapy, and then I got involved in research. So I still practice physical therapy and manual therapy 1 day a week, but I'm also working as an associate professor at a university here in the Netherlands. And I'm also a board member of different organizations, national organizations, and international organizations. For example, I'm also involved in the Dutch Manual Therapy Association and also in the International Manual Therapy Association, the IFOM, International Federation for Orthopedic Manipulative Therapy.
Awesome. So let's jump to our topic. So what are the most commonly reported adverse events after manual therapy in the literature?
Yes, luckily, Rick Kranenburg is also from the Netherlands. I'm in the south of the Netherlands, and Rick lives in the northern part of the Netherlands. And he conducted a systematic review on this topic. So it's very easy to answer this question. But of course, we can discuss it more in depth, I guess, because the most reported serious adverse event after manual therapy is the vertebral artery dissection. So that's by far the most commonly reported adverse event. And saying that, it is the most reported, but it's still very, very rare. And after that, you also have, of course, some disc ruptures that can occur after manual therapy, and also the dissection of the internal carotid artery. But on top is the dissection of the vertebral artery. So that happens, so quite a lot. It happens the most from all serious adverse events. But it's, as I said before, it's still very, very rare. And when we talk about dissections, I always think it is important for people also to know what is a dissection, because some people they don't really know what it is about. And the dissection is just an intimal tear. So the inner blood vessel is teared, and then there will be a hematoma in the vessel wall, and that can cause an occlusion of the blood vessel, and then of course it will limit the blood flow. And basically, such a dissection is not always a very big problem, but because many of these dissections also resolve from themselves, so they don't need any treatment. However, especially when there is an emboli, then that can obstruct the blood flow to your brain, of course, and that is very, very problematic, of course. So, and then you see all these symptoms, and then we have a problem, of course. But basically, the mechanism of the dissection is not that bad. And as I said before, most of them resolve within time. And also, people always, or not always, but some people think that every dissection needs surgery, for example, but most dissections are just treated by medication. And then the problem resolves itself during time. But that's important for people to know what is the mechanism, so what's really happening. And I guess then as well, because this question is also, manual therapy is sometimes blamed for causing these serious adverse events. And then also, we talk later, I think, also about the IFOMT framework. It's a kind of guidance for clinical reasoning in patients with neck pain. And then we also see that the incidence of these serious adverse events, especially the vascular serious adverse events, is very low. And in the IFOMT framework, they compared that with certain medications and other adverse events like myocardial infarct or gastrointestinal bleedings. And then you see that basically the incidence, the absolute risk of having serious adverse events after manual therapy compared to those medications is very low. So it's not a big problem, but of course it can have devastating consequences if you have such an event. And of course, I think that we all see these kind of things on social media about manual therapy or chiropractors, and then of course there can be serious adverse events. So people know about it, and then sometimes they have some fear. And we also know, for example, in the Netherlands, a study was conducted about reasons that general practitioners do not refer to manual therapy, and one of the reasons that they don't refer is the fear of those serious adverse events that are associated with the treatment. And also patients who read newspapers, they can also develop some kind of fear for these kind of treatments. And that, of course, is a shame. And I think basically I do a lot of courses on this topic. And we also know from research that also physical therapists and manual therapists also have some fear for using these kind of techniques, and also think that manual therapy can be dangerous, for example, with regard to causing these kind of serious adverse events. And I think it's important to emphasize that, and that's also included in the IFOMT framework. We know that from research from David Cassidy, for example, that basically the manual therapy, the manipulation, is not causing that serious adverse event, that dissection more specifically, but it's more that people already have a dissection. They have first symptoms of a dissection can be headache and neck pain, and then they visit their chiropractor or their manual therapist or their physical therapist with these complaints based on that underlying vascular pathology. And then when it is not recognized by the therapist, of course, then you can aggravate that already existing dissection. So the problem with these serious adverse events is not that there is a causal relationship in most cases between the treatment and the dissection. No, it's a person with already an existing dissection who seeks care, and then the dissection is aggravated by the treatment.
Yeah, so that was going to be one of the questions I was going to ask you.
That sorry for answering it already.
You went ahead and already answered that people, it's not like as common with the manipulation, people are going to have the dissection, but they already have an issue that make them more prone to having that happening to them. So it's not like just the manual therapy is going to cause that.
No, we know that a healthy blood vessel generally will not be affected by manipulation or mobilization or other treatments. So that's not the problem. But when it's not a healthy blood vessel, if there is already a dissection, of course, then you can aggravate, you can make the situation worse with your treatments. And that's the reason that it's very important that we try to recognize those underlying vascular pathologies or blood flow limitations, because we don't want to treat those people, or sometimes we need to adjust our treatment, but we want to refer these people to the emergency department or to the general practitioner, depending on how bad the situation is at that moment.
Yeah. And when you say that's very rare, do you have any numbers just so we have an idea of what you're talking about?
Yeah, so these numbers, they vary in literature. I don't know, because it's really a broad range that it is reported. But it is very, very rare. So in the IFOAM framework, they say that the risk of the treatment on a serious adverse event is 0.005%. So that gives an idea that it is very, very rare. But it does not mean that those serious adverse events do not happen. So also in the Netherlands, I think the last decade we had about 20 serious adverse events. So these do happen, and of course it's a problem. And I don't want to be that therapist that treats a person who will develop a serious adverse event. But yeah, it is rare. Yeah.
And then you said that medication can treat it, right? So how do you diagnose, how you get to that point to know that you have to give the medication?
Yeah, so I think it's important to know that when we look at those vascular pathologies, it's a very broad range, of course. And basically, when we look at the cervical spine region, we have two very important arteries over there, the carotid artery and the vertebral artery. And within those arteries, a lot of pathologies can be present. So you can have stenosis, you can have atherosclerosis, you can have a dissection. All those kind of pathologies can be present. But I think that we can't really diagnose what the specific pathology is as therapists. We can have an idea. I will also talk about it later, I guess, about the differences between the presentation between a dissection, for example, in the vertebral artery or the carotid artery. So we can have an idea about where the problem will be. But symptoms of the different pathologies in the same artery, they overlap. So we cannot really diagnose it. So it's very important that we know all the signs and symptoms of these pathologies, and then I think the patient interview, the subjective examination, is really the first step that is very important in our clinical reasoning process.
Mm-hmm. Okay, I'm just jumping ahead of myself here, asking all those questions. We're gonna get there. So first, what are the mechanisms or factors that lead to vascular flow limitations?
Yeah, so as I said before, you have those based on stenosis or atherosclerosis. But I think it's very important to emphasize that we also have those blood flow limitations, because in the IFOAM framework, basically they focus on pathologies. But we also know that it is not always pathology, vascular pathology, that can cause these blood flow limitations. And maybe I also a little bit too early to discuss this, because I know we had a preparatory meeting, and we also, this is one of the questions, but we also saw that there are some pathologies of some blood flow limitations that are not really vascular pathologies. So, and those are examples of Bow-Hunter syndrome and Eagle syndrome. And that's important to know, that it's not always a vascular pathology, but it can also be just a compression on an artery without a vascular pathology. And that's important. And that can occur everywhere in the body. You can also have that in your arm or your leg or everywhere, but that can also happen in the cervical spine region.
Mm-hmm. So it's like a sternal mechanism, just compressing the flow, not a problem on the flow itself.
No. So the artery is healthy, but external compression from the muscles or from bony from bones can also compress the artery, and that gives a little bit of the same symptoms as those vascular pathologies, of course. So that's also something we cannot diagnose often, because we don't know exactly what's happening inside the body. So it's not our job to diagnose what is really happening, but it is just to raise awareness and to refer that patient to the care that they need.
Yeah, absolutely. So let's talk about the symptoms. I think that this is very important. So what are the symptoms that make you think about a vascular pathology or a blood flow limitation?
Yeah. So I think that's very, very important, because that's the first thing that we notice and that we also addressed in our subjective examination, of course. But it's not always that easy and that clear, because we know that the most commonly reported symptoms from, for example, dissection, but also other pathologies in the cervical spine region, are headache and neck pain. So people visit us as therapists because they have headache and neck pain. And of course, not everyone who has neck pain or headache will have a vascular pathology or blood flow limitation. But it's important to know that that is really the case. And then, of course, we have also some other symptoms like visual disturbances, paresthesia, dizziness. So these kind of symptoms are also symptoms of a potential vascular problem. And to make that more clear, we often also look at the two arteries that are most commonly affected, so the vertebrobasilar artery, the vertebral artery, and the internal carotid artery, because these symptoms will also be different in each artery. And I think that is also important to know that, as I said before, the first symptoms often are just headache and neck pain. So people develop a dissection, for example, and then the first symptoms are neck pain and headache, and that's also the moment that they visit us as physical therapists. With headache and neck pain, when you have direct access in your country, people just go to the therapist. So that's basic. We have a somatic pain response at that moment, and there are no ischemic symptoms at that moment. But later, when the pathology progresses, then you have also these ischemic symptoms, and I will discuss them later. So that means that there are hindbrain ischemia symptoms, cranial nerve palsies, and eventually people can have a stroke, of course, and then you can all have all these kind of symptoms. And that mechanism of the increase in symptoms is the same, more or less the same, in the vertebral artery as well as in the internal carotid artery. And especially in the phase when there are no ischemic symptoms, and that continues to have that people have those ischemic symptoms, that's the phase that we can possibly identify those dissection-related events, because then they have, for example, with the vertebral artery, people feel unsteady, they have difficulties with talking, they have nausea, they have facial palsies, weaknesses in the upper and lower limb, all those kind of symptoms. These are not really normally associated with neck pain, and then we can identify these kind of symptoms. And then we know that when there is a dissection in the vertebral artery, the pain is mostly distributed in the upper cervical spine, also occipital headache, and also people always often say that there is an acute onset of the pain, and the pain is described unlike any other. So that's with regard to the vertebral artery. And when you look at the internal carotid artery, it's more or less the same, that people always often say that there is an acute onset of the pain, and also they have never felt that pain in the past. But then the pain is more distributed in the upper cervical spine region, and pain around the ear and the jaw. And also there's also head pain in front of their head. And then people with a dissection, a carotid artery dissection, have also ptosis, that is the hanging upper eyelid. They have also weaknesses in the upper limb, facial palsies, also speak and those kind of problems, also unsteadiness and those kind of things. So it's always also difficult, because these signs and symptoms are also both present in dissection of the internal carotid artery and the vertebral artery. The pain distribution is different, signs and symptoms, the ischemic signs and symptoms overlap. So ptosis, you don't see ptosis often in the vertebral artery dissection, but it can be present in case of a vertebral artery dissection. So you cannot use it to diagnose, I guess. But those kind of symptoms are very important. And then one thing is good to emphasize that although we say that people often have the experience that it is an acute onset of the pain and that it is their worst pain ever, we also know that in about 25% of the people, this is not the case. So you cannot conclude that it is a gradual onset of the pain, that it can't be in a dissection, or when they only say it's not my worst pain ever, you can't rule out a dissection because in 25%, they show different features.
But if they do have an acute onset and is the worst pain ever, then just helps you to discern between a normal musculoskeletal neck pain and headache versus something vascular.
It's one of the components, of course, because not everyone who has those features will have a dissection, of course, because people, you don't know what pain experience they already have. So maybe people who have just muscle problem also say that it's an acute onset, and perhaps it's also their worst pain ever. So there are more factors that we should look at than only the pain features or the pain distribution, of course, and especially those other features. So like vision problems, hearing problems, and those kind of things, speech problems. Those kind of things are very important also to assess.
Mm-hmm. And how about on the non-ischemic stage? That I think it's probably the hardest to differentiate between like just a musculoskeletal headache and neck pain versus the vascular.
Yeah, that's very, very, very difficult, of course. So in that phase, the pain that people experience is referred pain from the blood vessels. And of course, it's difficult to differentiate between that pain, that referred pain, and normal pain from musculoskeletal origin. And that's the reason that it's not only about the pain distribution and the pain features, but also from the history. The patient history is very important because it also makes sense. If there are other risk factors present, then it will, that will change the way you look at that particular case, of course.
Yeah. So like in the subject, anything else that you look for other than like the symptoms that they describe, the onset of pain and all these ones that you already mentioned? Anything else, like you said, risk factors, so family history? Anything else that you look at in the subjective?
Yeah. So if we look at how can we identify those vascular pathologies and blood flow limitations? The first thing are those really clear ischemic features. So if those are present, then you have a high level of suspicion. The pain distribution is also one part, of course, and then of course you also have to look at those other features. So, for example, the risk factors that can be present. And with regard to the risk factors, it's always, now I don't know if it's nice, but when I give a course, I always have a kind of statement, and then I have a kind of statement, and I don't know if I remember words correctly, but the statement is cardiovascular risk factors are associated with a high risk of a vertebral artery dissection, or cardiovascular risk factors are associated with a high risk of a carotid artery dissection. And basically, always about 80% of the people in my courses, they agree with that statement. So they really believe that cardiovascular risk factors like hypertension, smoking, so those kind of things are associated with a high risk of a dissection. But that is not the case, because when we look at risk factors, we differentiate between dissections and dissection-related risk factors and the non-dissection-related vascular pathologies based on atherosclerosis, for example. So when we look at those non-dissection related events, we know that people who smoke or smoked in the past have a higher risk. We know that hypertension is a high risk factor for these non-dissection vascular events. High cholesterol is also a risk factor. But when we look at the risk factors for dissection vascular events, then we see that the most important and most frequently reported risk factor is the trauma. And that can be often a recent trauma, but sometimes also a little bit longer ago. So that's the most important risk factor for dissection-related vascular events. And the second one are vascular anomalies, because we're not all the same. So those differences between the anatomy of the vertebral artery and the bony structures there are also a risk factor. And then we have also in the lists, they also list smoking and high cholesterol and hypertension. But if you look at the percentages of the percentages of the people that have these kind of cardiovascular risk factors in people who also experience a dissection, those figures are lower than the general population. So, for example, let's see at high cholesterol. If you look at the people with a dissection, and I think 23% or 25% of the people who have a dissection also have a high cholesterol. But if you look at the general population, about 40% of the people have a high cholesterol. So those cardiovascular risk factors are no risk factors for the dissection, but for non-dissection vascular events. So that's always nice. It's good to learn that to people, that you should differentiate between vascular, just so general thrombotic stroke, for example, and the dissection vascular events, because the risk factors are different. And then, of course, it's always difficult for us to diagnose again. So we cannot say we are sure that it is a dissection but it's important to know that these risk factors are different, and that especially when we look at dissections, these are most commonly reported in younger people, especially females, below the age of 45, 50. So there's also a very specific group that often are affected by these dissections, and then so you see that the subjective examination, the patient interview, is the most important, and then of course another important aspect is of course the physical examination, so the objective examination, which is also very important. And maybe before we maybe touch on that, it's also important to emphasize that when we look at the physical examination, but cranial nerves are very important, because as well with problems, a dissection of the internal carotid artery, as well as dissection of the vertebral artery, that can result in cranial nerve dysfunction. And people sometimes know these cranial nerve tests and the cranial nerve examination, but you can also have some questions about these kind of things in your subjective examination. So about if people notice change in their ability to smell, to hear, to changes in their vision, those kind of things, you can also focus on that in your subjective examination before you enter the objective examination and can do all the testing.
Okay. So still on the subject of what did you say that females have more risk? Is that anything specific? I'm just curious.
No, I don't want to blame you. So basically, I gave this course last Saturday, so a few days ago, and I got the same question. We don't know that exactly. At least I don't know it exactly. So.
And is that associated with trauma or not?
Perhaps I don't know what the exact mechanism is behind it, of if young females have more traumas compared to men, or that have other effects in their body. I'm not aware of that. So I'm not able to answer that question.
Yeah.
I guess.
Okay. And on the risk factors that you said that they were different, the non-dissection risk factors. is that also like for people that have higher cholesterol and hypertension, are they more prone to develop vascular events in case of manipulation? Is there any relation to that, or is more related to dissection?
Yes. So what we see, because I said before, especially younger people, females, develop a dissection. And those cardiovascular risk factors are no risk factors for dissection. Those cardiovascular risk factors are risk factors for thrombotic stroke, for example. So in the older people who have arteriosclerosis, so 60, 70, they can have a non-dissection event based on a thrombotic stroke. But those are generally not the people that we treat or manipulate, I guess, because we more focus on the I would be not too happy with manipulating a 75-year-old lady, or so. It's more that for the dissection events, the cardiovascular risk factors are no risk factors, but they are risk factors. So it's important to identify those risk factors, especially in the older population, because then, of course, they can have a thrombotic stroke or something like that. And you also want to diagnose that and to refer that person to the GP or to the emergency department, because it's not a dissection, but it can also have devastating effects, of course.
Yeah, so that's how I was curious, because if you have patients, for example, young population that have high cholesterol and hypertension, would that be something that you would be careful with manipulating, or not necessarily?
So when you look at those list of risk factors, we know that it is not associated with those dissection events. So of course, you should keep that in your mind, because you don't know exactly what's happening in the body, of course. So you should keep it in your mind. So don't ignore it. But you also should know that those are not really the risk factors that are associated with a dissection event. So I think there are more important risk factors. So the trauma is very important. So I also know cases that there was a clear trauma and that it was neglected by the healthcare professional, for example. The tricky thing is the vascular anomalies. So because we don't know that, we don't have imaging of the vertebral artery, how that is deviating at the upper cervical spine. We don't know all the bony changes, especially also when people get older, but we don't know how that is in that particular patient. So vascular anomalies are present in about 40% of the people experiencing a dissection in the upper cervical spine. So, and that's a kind of problem, because we don't know who has a vascular anomaly. For trauma, we can ask, but anomalies, people don't know if their anatomy is from the textbook or that they have something else. And that's the kind of thing that it's difficult.
That's tricky, because there is no way you can know. very difficult.
No. So that's the problem.
Yeah. And we were talking about the thrombotic stroke. That's probably very rare also, I would imagine, right? With the non-dissection vascular events. Would that be very rare?
No. Yeah, so of course, that is also this, as well as the dissections, those are not caused by a treatment, of course. But people also can have a thrombotic stroke and can also have pain based on that thrombotic stroke, of course. But especially with the kind of the dissection, you really see a first phase with only headache and neck pain. And maybe this is less pronounced in people with thrombotic stroke, because people who have a stroke, people really recognize it often because it's very acute, and also their surroundings recognize it as a stroke, basically. And then they will not come to you as a physical therapist, while these patients with dissections already have the dissection and have headache and neck pain. And of course, that can also be the first features of thrombotic stroke. But especially in dissection, that is the problem.
Yeah, it makes sense. And so let's go to the objective. So is there any risk assessment, any cervical tests? So how do you go about the objective?
Yeah. So first, so IFOMT, the International Federation of Orthopedic Manipulative Therapists, has an IFOMT framework, which can be very helpful with regard to guiding you through the clinical reasoning process and then also through the physical examination. And then basically they have kind of 4 components of the physical examinations. That's the neurological examination, so the peripheral nerves and the cranial nerves, consideration of coordination and gait, blood pressure measurement, and auscultation. And what is important is that one of the other questions I always ask is what kind of physical tests do you use in your physical examination to rule out a vascular pathology or blood flow limitation? And 80% of the people always then uses the vertebrobasilar insufficiency test, so the VvAA test, the positional testing of the cervical spine. And previously, those tests were also included in the IFOM framework. But I think in 2012 or so, we published an article about the diagnostic accuracy of those VvAA tests, and the sensitivity was very low. So that means that we have many false negative tests. And what is the problem with a false negative test? That the test is negative, but people can still have an underlying vascular problem. So you think you're safe, the test is negative, you treat that person, but basically you put that person at risk. So that's the first thing, that based on that the sensitivity of that test, the VvAA test, we cannot recommend that test anymore. So that's the first important thing. And I always also say that the mechanism of the test is basically you do 3-dimensional extension rotation, and then you try to compress or occlude the opposite vertebral artery. And because the test thinks that it occludes that artery, you test the compensatory mechanism of the other vertebral arteries. Because if you have occlusion here, perfusion to the brain should be continued, and then you test the compensation mechanism of the other vertebral artery. But first, we know that we also have the anterior system with the carotid artery, and we have the circle of Willis. So basically, you cannot test the other vertebral artery in isolation. You always test the whole system. But what we also know is from research that when you do the test, you don't see a decrease in blood flow in the contralateral artery. And that means that if you don't see a decrease in blood flow here, you also are not testing the other vertebral artery if they can compensate. So basically, the whole mechanism behind the test is also not valid. That's important, and still the test is used by many manual therapists, physical therapists. But basically, we can say that the test does not add anything. Especially, people think they are safe to continue after a negative test, but basically they are not, because the test does not add anything to the information that you already had obtained in the subjective examination. So my message is, don't use these tests anymore, but really focus on blood flow measurements, and especially the cranial nerve examination is very important, because we know that problems with the carotid artery and the vertebral artery, especially dissections, can give positive cranial nerve tests. So that's very important, that you know how to test the cranial nerves.
Okay.
And we can talk about it very long time, but then you really need to have a course and trying to do these tests yourself, of course.
I think one of our papers had all the pictures, right? And showing cranial nerve.
Yeah. So we had
examination.
Yeah. We published a few papers about this topic, and one of them is very nice, that gives an overview of all the vascular blood flow limitations. It is published in the Brazilian Journal of Physical Therapy. That's very, very nice to read. But the other one, in the Journal of Manual and Manipulative Therapy, is also about the cranial nerve examination. So we have one whole article describing the whole cranial nerve examination, including a kind of summary with all kinds of pictures and those kind of things. So that can be a good start for people to learn about this cranial nerve examination if you're not familiar with it.
Okay. So cranial nerve examination, and then you said test the flow. You said something else.
So that's it, and then blood pressure, for example.
Blood pressure. Okay.
Yeah. So that can be an important component, especially in my personal opinion, especially in the older population, because there you see that those cardiovascular risk factors play a role. Also, if you really expect a person to have a dissection, because when there is a vascular event happening at that time, there can be also an increase in blood pressure. So that is one of the things that you could find when there is a acute problem, that there can be an increase in blood pressure. But that can also be present in younger people. But in the older people, we just know that high blood pressure is a risk factor for all those heart problems, etc. So you can use those tests as well. But personally, I do not recommend it to do the tests in every patient because that might not make sense, I guess. But of course, it's good based on your subjective examination, you decide which tests are appropriate, of course.
Yeah. And on the neurologic component, anything else that you want to highlight?
No, I think that basically the cranial nerves are very important, because most therapists also know how to use the tests for the peripheral nerves, but often, and it can be dependent on the country in which you were trained, but often the cranial nerves are a little bit neglected. For example, in that same course I had this Saturday, I think we had about 15 or 16 people there, and only 2 of them were trained in the cranial nerve examination. And that, I think that's a problem, because I think you should not use those tests in every patient, but there are patients that it is appropriate to use these tests. And when you are not familiar with the tests, you will not use them, of course.
Yeah. So in your opinion, is the peripheral nerve examination is also important?
It can also be important, but when you look at the dissections, then we know that so the cranial, when there is an internal carotid artery dissection, then we can see cranial nerve palsy. So there will be positive cranial nerve tests, and that's also the case for the vertebral artery. Especially the lower cranial nerves can be affected in case there is a dissection of the vertebral artery, and that's cranial nerve 5 to 12 are the most affected cranial nerves when there is a dissection of the vertebral artery. So those will really cause those cranial nerve deviations, these palsies. So it's important to test especially the cranial nerves as well then. Okay, awesome. And then moving forward on the objective, anything else that you want to mention that's important? Yes, so just to mention, so in the gait, you can let people walk and do some tests, coordination tests, Romberg's test, for example, to differentiate between a problem of the cerebellum or another problem, and also is the IFAM framework also palpation and auscultation of the carotid artery is also included. So palpation is what we also use in the Netherlands. Auscultation is not what we use in the Netherlands, but you can also evaluate that, of course. And we don't know the diagnostic accuracy of all these tests, auscultation, palpation. Also with regard to blood pressure, we don't know what the really diagnostic accuracy of blood pressure measurement is with regard to identifying an underlying vasculogenic contribution to the complaint. So we should keep that in mind. We don't know how valid all these tests are, but it is good to have some tests that we can use. And the vertebral artery tests, so the VvAA tests, are not valid, so don't use these. But be aware that those other tests are also not, we don't know the validity of these other tests as well. Okay. And when you said there was like 4 components to the objective, which one are those? Just to be clear. Yeah, so the first one is the neurological examination, cranial peripheral nerves. Then the coordination and the gait, so a gait assessment. the blood pressure measurement, and then the palpation and auscultation of the carotid artery.
Awesome. Perfect. Okay. And so if you see a patient use manual therapy, manipulate, what would be a normal versus abnormal reaction, and how do you instruct the patient in like what the patient should expect?
Yes, I think that's a very important question, because I give this example. A few years ago in the Netherlands, there was a case of an adverse event, a vertebral artery dissection, and that person that had already a little bit dizziness and increased pain after the treatment. But then when she came back to the therapist, she also said that she had experienced a walking deviation the day after the treatment. And in this case, then the therapist informed the general practitioner by a written letter. But eventually that patient was diagnosed with a vertebral artery dissection. And then you can think about that, because what if the patient would have known that a walking deviation is not a normal symptom after a treatment? Because if people know that, then they might be able to contact the therapist or their GP, for example, when they experience these kind of symptoms. So what we propose is and we publish it in the Journal of Orthopedic Sports Physical Therapy, JOSPT, recently, is that within physical therapy, we also should use a kind of principles of safety netting. And safety netting is also used by general practitioners if they have a person, and for example, when they might think about this could be a cancer, for example, they need to inform the patient, because they want to see how that is progressing or how that is going in the time. And then they give some advices to the patient. So the things that the patient should look at is, we should know is what kind of signs and symptoms they should be aware of and should be look out for. If they have these kind of signs and symptoms, what action then should they take, and the time frame within that action needs to be taken. So, and then people are a little bit prepared. And I think that so the general practitioner uses that in months, of course, because they want to know if that the disease progresses, that people should contact them. But in physical therapy, we can use that between our sessions. So I believe that when you have a kind of you see that person with a kind of few concerning features, and you think about a possible vasculogenic contribution to the complaints, then you do your whole examination, objective subject examination, and at the end, eventually, you reject that vascular hypothesis, but it was in your mind. And in those patients, it could be a good idea to use these principles of safety netting. So you can just tell patients what kind of symptoms they should be aware of. If they experience these kind of symptoms, what action should they take? So should they call you or should they go to their GP? And also the time frame. So there might be symptoms that we need immediately action, and some symptoms might take some days. And I think that could be very helpful, because now we don't really inform our patients that well, I guess. And of course, there is a kind of risk because we don't want to create anxiety in patients. So if I tell that person in front of me, if you have a walking deviation or you have vision problems or that kind of things, so that is not really nice for a person to hear, and they might be concerned and they might be anxious, of course. So what we propose is that when there is only a low level of concern after your clinical reasoning, that you do provide information about the normal course of the treatment, of the condition, and also what can happen after the treatment. So people who have manipulation and mobilization, for example, can have increased pain. They can have headache, some dizziness, muscle soreness, those kind of things. And usually that resolves within 24 hours. So you can tell people these are normal symptoms. And you can also say, if you have any other symptoms, just call me. So that's this kind, you don't mention those specific symptoms, but you just inform them about what is normal. But when there is a high level of concern, of course, then you do not do any treatment. Then you refer that person to emergency services or the general practitioner. But in that intermediate level of concern, then we believe that it could be appropriate to provide some specific information about those signs and symptoms that are abnormal. Because I think patient safety is very important. We don't want to worry our patients. We don't want to make them anxious. But in an intermediate state, so if that person, which I was referring to, would have known that the walking deviation was not the normal symptoms, then she could have phoned her GP earlier, and maybe that could have changed the outcome of that serious adverse event. So in that intermediate level of concern, we believe that it could and sometimes could be appropriate to give some more information about those abnormal signs and symptoms.
Okay. And the examples of those signs and symptoms are the same that you already mentioned before, right? Earlier.
Yes. So those are more or less the same. So in that article in USPT, we also created a kind of infographic that can be helpful, because basically we say, it's a very summarizing infographic. We say normal symptoms that can be aggravated after a treatment are pain, stiffness, headache, dizziness, and tiredness. And the abnormal symptoms are unsteadiness, dysphagia, dysarthria, aphasia, dysphagia, upper limb or lower limb weakness, ptosis, and facial palsies. So these are abnormal signs and symptoms. It's basically 6 kind of symptoms that you could also show to your patient, for example. They don't have to have the whole list, but those 6 symptoms are things that are considered abnormal in summary.
Okay, and you have that on a paper, right? I think I read that.
Yeah, so we published a few points. It was published this year in USPT, and that is really about what I told you in the last 5 minutes about what should we tell our patients, how can we provide that specific information and advice to our patients. Because that was often neglected. So we focus on risk factors and those kind of things. It's very important. But then we forgot a little bit about informing our patients about what is normal, what is abnormal, because from those case reports, we know that it is important that patients have a kind of idea what they can expect after a treatment. Because if they don't know, they will not call you if they have these kind of symptoms.
Yeah, or not even relate to the treatment or anything.
They might know. They might think it's a normal sign and symptoms. And we have included 2 cases in that article, in which I believe that it could have made a difference to the patient.
Mm-hmm. Yeah, it's good to read those examples. I thought that was nice.
Yeah. So then you get an idea of
Yeah. And about the framework that you mentioned before, so that was one of the changes, right? The test that you mentioned. Anything else that you want to mention about any changes or anything from the 2012 to 2020 framework?
Yeah, so basically they also changed. So in the previous framework, they talked about cervical artery dysfunction, and now they talk about vascular pathology. So that's more specific, and I think they just changed the terms, and that's a good thing. That was also one of my points of criticism of the older framework. So I'm happy that they changed it. What they also did now is that they basically really differentiate between the dissection-related events and the risk factors for dissection-related events and for the non-dissection-related events. So that's good. It makes sense because those risk factors, we saw these risk factors differ. The signs and symptoms of vascular dissection-related events and non-dissection-related events are generally the same. But the percentages differ, but they are generally the same. But the risk factors, they really differ. So they separated those things. And also besides the removal of the VBI test, so the provocation test, they also deleted the test for the upper cervical spine instability, which were included in the previous framework, but are not included in this framework anymore. And I think basically that's more or less that are the major differences. And of course, they fully updated the framework, and some things are described more extensively, also with regard to the physical examination. But basically, those were the major differences. And maybe good to emphasize that the test, the framework is not really, it is a kind of guidance. So it's not a kind of diagnostic test, for example, which can be positive or negative. It's just a guidance through the whole clinical reasoning process, describing things that are important to consider. And it will be a challenge to identify a potential vasculogenic contribution to the patient's complaints from the patient that is sitting in front of you. But if you follow the framework, you at least have an idea of what components are important to evaluate. And then basically you can have that high suspicion or low suspicion or intermediate suspicion. But it's not easy. It's not easy to do this, of course.
It's not as simple as
No. I can. Yeah. So and also when you look back at those cases, it can be very clear. But it's always easier to look back on those cases and say, "Oh, this went wrong. That went wrong." But yeah, so it's not easy.
So like now the trick question. So do you think it's safe to mobilize and manipulate on the cervical spine?
Yes. So basically, it is important to know first also that the iPhone framework is not focused on manipulation. It's focused on a broad range of manual therapy, which include manipulation, mobilization, and exercises. And also, we also know that because there is already an existing dissection, for example, and we should identify that underlying vascular pathology. So it's not really about the treatment that we use. It's not about mobilization, manipulation, exercises. It's about that we should identify or try to identify that underlying vascular pathology or blood flow limitation. So it's not about the treatment. It's also not about, because those people can also go to their hairdresser and also that can also aggravate that already existing dissection. So I think it's safe to use manipulation and mobilization in healthy people, on healthy blood vessels. I think that's very, very, very safe. The problem is when you do that on already existing vertebral artery, for example, then of course there can be some problems because you can aggravate that condition. It is already there. It's also likely to aggravate by other causes in the near future as well. But that is what we should keep in mind. So I think it's safe, but we should do anything to prevent that we are treating manipulation, mobilization, or doing exercises, whatever, on patients that already have a vascular pathology. And it's not about it's our responsibility to identify this and to refer those people to appropriate care. So I don't see the causal relationship in 99.99% of all the serious adverse events between the manipulation or treatment and the serious adverse events. So it is already there. But yeah, so we should keep that in mind. And some people say then better safe than sorry. So why not only do mobilization instead of manipulation? And that's also the specific preference of every therapist. So basically, when it is already there, that dissection, both mobilization and manipulation can aggravate that already existing dissection. So it is really also about the discussion. What is your preference as a therapist? What is the preference of the patient? And that's the shared decision-making process. And then it's a risk-benefit analysis in every patient. But I think generally we can say treatment of the cervical spine is safe.
Okay, good answer. Long, good answer. If people want to learn more about the topic, Nathan, anything that you recommend them to read?
Yeah, so I think basically just when you, I don't want to...
All those papers.
focus on myself, of course. But I think so what is nice nowadays is that also in the scientific journals, and not only those study reports are published, but also these kind of viewpoints or master classes. So if you look at my name in PubMed and you find these master classes and viewpoints about this topic, and these are easy to read and they really provide some practical guidance to the whole clinical reasoning process. So that would be the first recommendation, I guess.
Yeah, when I asked you about resources, you sent me a list of papers, so that was very helpful. A lot of papers,
so it's not published in literature. So and it's not so it's not that difficult to read, I guess. So I think that's going to be a good first step.
Yeah, and any advice to clinicians that are starting their careers?
Yeah, so basically, I think generally when you start your career, be curious. I think it's good attitude to want to develop yourself, because when you're just starting, maybe you think you know everything, but basically you don't know anything. So just make a kind of plan for how you want to develop yourself. I think that is very important, because development is throughout your whole career, of course, is important, but also when you are just starting, make a plan. What are your interests, and just continue with doing some education or courses.
Yeah. And any personal qualities or abilities that you think are important to become successful?
So again, I think the fact that you want to improve yourself, want to learn, I think that is very important. And when you look at our profession, I think it's to be successful as a physical therapist, I think communication is really key. So you can have all the technical skills and those kind of things, but we more and more know that it's basically about communication and your communication style. Building that therapeutic relationship is more and more important. One of my other research topics is about those kind of things as well. So I think that is really a good quality. So invest on those communication skills that will make you a better therapist at the end.
Yes, makes total sense. And Nathan, if anyone wants to learn more about you or get in touch, is there a way that they can reach out?
Yes, of course. You can just find me on Twitter, for example, because Twitter can also be a good resource, for example. But you can also send me an email, of course. So that's all possible, and I will respond as well.
Awesome. Nathan, thank you so much for taking the time and share all your knowledge and expertise on the topic. It was very helpful. So I'm sure all the listeners really appreciate. So thank you so much.
Yeah, thank you for having me. And I really enjoyed our conversation.